Welcome to the voice-annotated presentation about multiple sclerosis. My name is Michael Pytek, and with the help of my faculty advisor, Dr. Jody Hawes, have created this PowerPoint to help with learning the basics of MS. The learning objectives for this presentation include recognizing the epidemiology, pathology, and pathophysiology of multiple sclerosis, or MS, identifying the most common clinical presentations of MS. I will go through the criteria and methods of diagnosing MS. Finally, we'll talk about treatment and the prognosis of MS. The outline of this talk is as follows. We will cover epidemiology, then pathology, pathophysiology, risk factors, clinical course, diagnosis, treatment, and prognosis. There are approximately 400,000 patients in the United States with multiple sclerosis. It occurs most commonly between the ages of 20 to 40, with median and mean ages of 23.5 and 30 years. Typically, patients with the relapsing remitting form have an earlier onset than other types. There tends to be a ratio of 2 to 1 for females compared to males. The exact cause of MS is not known, but the mechanism has been well described through histopathologic examination. MS is an inflammatory autoimmune disorder of the central nervous system. What we see are lymphocytes crossing the blood-brain barrier and targeting myelin antigens. It is characterized by inflammation, demyelination, reactive gliosis, and oligodendrocyte and axonal loss. Demyelination is the primary pathologic feature. However, axonal loss is also an important pathological finding. Both correlate with disease progression and disability. The etiology is unknown, but genetic and environmental factors are thought to contribute. There are individual genes which confer susceptibility, and there are greater than 20 risk loci identified in genome-wide association studies. A viral or other microbial agent may explain the reaction, which has included Epstein-Barr virus, varicella-zoster virus, or other early childhood infection. Geographically, the incidence of MS increases from south to north. Little is known about the explanation for this, but multiple theories include race, exposure to sunlight, and other environmental triggers. It does appear that the risk is associated with the location where an individual has lived prior to puberty. Other risk factors include vitamin D, smoking, and pregnancy. The initial or presenting symptoms of MS are nonspecific and variable. Common symptoms which should raise a red flag include the following: optic neuritis, which presents as acute or subacute unilateral eye pain with sudden loss or blurring of vision in that eye; internuclear ophthalmoplegia, which will present as diplopia, worsened unidirectional horizontal gaze; sensory complaints such as numbness or tingling; vertigo or disequilibrium; motor complaints such as weakness or paraparesis. Reflexes may be increased associated with spasticity or even decreased on location of lesion. There may be deficits in coordination manifest as dysmetria, ataxia, or even nystagmus. Even dysfunction in the bowel or bladder and sexual function are seen in MS and quite common. The clinical course of MS is variable, and there are 4 commonly described patterns. Relapsing remitting MS, the most common, accounting for 85 to 90%. It is characterized by relapses or attacks with either full recovery or persistence of residual deficits and no progression in between periods of relapses. Primary progressive is characterized by continuous disease progression with a steady decline in function without ever having any relapses. Secondary progressive is when an initial course of relapsing remitting MS is followed by a change in disease course to that of progression as seen in primary progressive. Finally, progressive relapsing MS shows progression of disease in the periods between acute relapses. There is no one test we can perform to diagnose MS. We therefore have different criteria, but the clinical presentation is the central feature. There are clinically isolated syndromes in which we have the symptoms, and radiographic isolated syndrome, where the imaging findings are suggestive of MS. We frequently use imaging such as MRI, CSF findings, and evoked potentials to help with the diagnosis. Multiple sclerosis is a clinical diagnosis which requires evidence that at least 2 regions of white matter have lesions occurring at different times. This is reflected by the McDonald criteria. Recent revisions have incorporated the use of neuroimaging and are based upon clinical and MRI findings. Dissemination in time can be proven by showing asymptomatic gadolinium-enhancing lesion or lesions in the presence of non-enhancing lesions. new T2 lesions on follow-up MRI, or the occurrence of a second clinical relapse. Dissemination in space is proven clinically by symptoms implicating a different CNS location or by lesions on MRI in two of the following four MS typical regions: infratentorial, spinal cord, juxtacortical, or periventricular. As per the guidelines for clinical criteria in the diagnosis of MS, MRI plays an important role. Lesions seen as cerebellar or spinal plaques of demyelination with preservation of axons. Most typically, these plaques are seen in the periventricular region, corpus callosum, centrum semiovale, and occasionally the deep white matter structures. Sometimes described as Dawson's fingers, plaques will appear to radiate at right angles and have an ovoid shape. They are hyperintense on T2 weighted imaging and hypointense on T1. Active lesions will have increased signal intensity on T1 images with the administration of gadolinium. Other tests which may provide supportive evidence of diagnosis include cerebral spinal fluid studies and evoked potentials. In the CSF, we look for oligoclonal IgG bands, which are found in 95+% of patients with MS. Comparisons to levels in the serum are made to the CSF. False positives may occur as other disease processes may also result in oligoclonal bands in the CSF, such as CNS infection, viral syndromes, and neuropathy. The leukocyte count, protein, and glucose are typically normal. Evoked potentials are used to detect abnormal CNS function in somatosensory, visual, and brainstem pathways. Identification of a lesion in these studies supports diagnosis of MS. The differential diagnosis of MS is as follows: acute disseminated encephalomyelitis, neuromyelitis optica, idiopathic transverse myelitis, idiopathic optic neuritis, vasculitis, sarcoidosis, and cerebral autosomal dominant arteriopathy with subcortical infarct and leukoencephalopathy, or CADASIL. The treatment for multiple sclerosis is split into two categories. Treatment of acute relapses is typically with glucocorticoids, the most common regimen being intravenous methylprednisolone, 1,000 mg daily for 3 to 7 days. This may or may not be followed by a steroid taper. Disease-modifying therapy is usually reserved for patients with relapsing remitting disease. Most common options include interferon beta-1b, beta-seron, interferon beta-1a, Avonex and Rebif, and glutamine or Copaxone. Randomized control studies suggest these have similar effect on disease progression. The important differences between these being frequency of injections and side effects. Fingolimod, or Gilenya, is a newer oral medication that sequesters lymphocytes in the lymph nodes, preventing CNS penetration. Long-term safety data, however, is not yet to be established, and to date 11 deaths have been linked to its use. Natalizumab or Tysabri is another option for treatment. However, it has been associated with development of progressive multifocal leukoencephalopathy, which is a fatal disease. The long-term prognosis can be highly variable in MS. At this point in time, there is no way to predict the frequency or severity of relapses. There are, however, some factors which help us predict a more favorable prognosis, such as age of onset, with younger age of onset and female gender being more beneficial. Patients with relapsing remitting disease tend to do better than those with progressive disease. Multiple studies have been performed to correlate lesion load with disease progression, and up to this point MRI lesion burden has proved a poor measure. As MS can affect women in their childbearing age, the relationship between pregnancy and progression of MS has been well studied. It has been shown that there is a reduction in relapses late in pregnancy. However, there appears to be an increase in the immediate postpartum period. To summarize, multiple sclerosis is an autoimmune inflammatory disease characterized by demyelination. Patients can present with a variety of neurologic complaints that can be localized to lesions in the white matter of the CNS. MRI provides a useful tool in helping diagnose MS and steer treatment. Acute exacerbations are treated with IV glucocorticoids. Multiple treatments are available to prevent relapses, including interferons, glutamine, fingolimod, and natalizumab. Prognosis can be variable, but multiple factors help stratify the risk.